Welcome everyone to today's webinar. I am Mackenzie Dean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. We will also have 3 audience poll questions throughout today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our presenters will give a few seconds for you to select a response from the options on your screen and click Submit. Poll results will also be shared with participants after the webinar. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Jason M. Cook is Assistant Vice President of Medical Management at Scripps Health. As Assistant Vice President of Medical Management, Jason is responsible for identification, evaluation, and implementation of medical group development strategies for Scripps Health, 5 hospitals, and numerous outpatient centers in San Diego County. Jason oversees health system and medical group integration while having overall administrative responsibility for the operational and financial functions of all clinical practice activities within several enterprise-wide medical divisions, including hospitalist, subspecialty hospitalist programs, pulmonary and critical care medicine, palliative medicine, and skilled nursing facility geriatric programs. Over the past 14 years, Jason has been instrumental in developing medical management solutions in partnership with local and regional affiliated medical groups and corporate operational leadership stakeholders. Jason has successfully led the evaluation and integration of multiple large medical group mergers and acquisitions over the past several years. Jason is the corporate executive responsible for the overall length of stay management system throughout Scripps Health and partners with the system Value by Design division to incorporate lean management models into the medical management practices of the health system. Felice Salzer, Director of Product Management, is responsible for Ingenious Med's analytics, insights, and commercialization process. She joined Ingenious Med with 10 years of product management and commercialization experience within the healthcare technology and medical device industries. Additionally, Felice has 18 years of clinical service as a board-certified nurse practitioner. She further holds an MBA as well as an MSN from Emory University in Atlanta. At this time, I am pleased to turn the floor over to Felice to begin today's presentation.
Thanks, Mackenzie, and welcome everyone to today's webinar, which will be centered around actionable data, the challenges facing hospitals, and how data can be utilized to paint a more complete picture of the overall health of an organization. And again, we're pleased to have Jason Cook, Assistant VP of Medical Management at Scripps, to join me today to give specific accounts of ways that he has leveraged data to assist his organization financially, operationally, and clinically. So let's dive in and discuss the scope of the problem. Lack of actionable data. The point of analytics is to empower the organization to unlock the meaning of data and put real-time knowledge to use in the decision-making process. About 85% of healthcare organizations feel unprepared in a value-based world. To succeed, they must leverage an analytics platform that will deliver actionable insights into their hands and the hands of their providers. In a world where fee-for-service is declining by 15 to 17%, it is imperative that organizations empower their providers with real-time data to use in the decision-making process. You see right now our current slide shows 4 major challenges for hospitals today. Jason, of these 4 main challenges facing hospitals, what has affected your organization the most?
Well, thank you, Felice, and welcome everyone to this webinar. In response, I wish I could say there's any one of these that are less important than the others, and clearly they all interconnected in the challenges we face. I think that the priorities of the organization have to look at how does the current fee-for-service revenue system fit with your pivot to a value-based model. In many instances, it's a discussion of when, not if, you're going to make that pivot. Part of your comfort in making that pivot to a value-based model is reliant on having appropriate documentation and analytics to assess where those opportunities may lie. We can talk further down in the presentation around specific tactics that Scripps Health used in all of these, but in summary, each one of these is critically important to the success of the organization moving forward.
Exactly, those are some great comments there, especially about appropriate documentation. So at this point, we would like to take just a moment for you guys to answer a survey question that you'll see popping up on your screen. As Mackenzie had mentioned earlier, the survey questions will be sent out to you all after the webinar. So if you'll take just a moment to answer which of the following challenges do you find most pressing after hearing those comments from Jason, that would be great. We'll give you guys just a few minutes.
And while the audience is looking at the questions, Felisa, I may add that there's clearly no single solution or the golden ticket for these challenges that hospitals are facing. And I think it's important to identify that what we'll talk about today with the IM solution isn't the only solution that can be added. It needs to be in partnership with the use of the electronic medical record that the institutions are using and other possible third-party vendors that are best practices that they can leverage the functionality of each system and what it's designed to do and actually close the gaps of what it's designed not to do. I think one of the fallacies is that Epic and or any other EHR is going to solve all of these problems, and from our experience, that just has not been the case. You need to leverage other products and augment the EHR with that functionality.
Absolutely, those are some great comments. Very good. Okay, great. So let's dive a little bit deeper into the fee-for-service decline. We took an opportunity and explored some missing revenue from a large not-for-profit health system. The research was conducted over several months. They determined the organization was losing approximately 22 to 44 million of unbilled physician fees on an annual basis. To recover these unbilled charges manually, they presumed it would require about 33 to 100 hours per physician per year. Those are just absolutely staggering numbers. Fortunately, as Jason also mentioned, there are partnerships to leverage within healthcare organizations and technology that can team up with those organizations to identify missing bills and benchmark against national norms. So if I can ask you, Jason, how has your organization partnered with some of those platforms to optimize fee-for-service revenue?
Thanks, Felice. I think it's important to acknowledge that our relationship at Scripps Health with IM dates back over a decade. And so the evolution of the value-based payment models has been something that we've been a close partner with IngeniousMed in helping us solve those difficult challenges. Along the journey when fee-for-service was king, and honestly, I think the biggest conversation with our organization is when to make the pivot from fee-for-service to value, recognizing that there was a lack of data to inform us of our existing performance, what target performance may be, and how do we take that jump into the unknown when the financial strength of the institution had been built on a well-understood fee-for-service model. So there's a couple comments I would make with regards to fee-for-service. And looking at the poll questions, I see that the top two respondents are difficulty supporting and succeeding in value and sharing real-time data across. I may focus my comments in those two areas. While fee-for-service revenue, particularly at our institution, is declining as a total percent of our total revenue, it doesn't mean that we can be distracted or forget about the tenets that made our fee-for-service revenue cycle so strong. So one of the ways we leverage the IngeniousMed platform is to recognize the work that's being done in the fee-for-service opportunities in Medicare predominantly, although we are transferring many of our bundles into BPCI programs under Medicare, so taking them out of straight fee-for-service. But it's to really document the work the providers are doing and then look at that against our revenue collection. The move to salary-based hospitalists and intensivists, as an example, took the emphasis away from charge capture and put it more on production, seeing patients, timely throughput. But we needed a mechanism to make sure we were still maximizing that fee-for-service revenue that we did have as part of our financial portfolio. So things like missing charges, E&M coding distribution review regarding different rounding teams or other programs at one site versus the other. Did they have similar distributions in their E&M level coding such that we were maximizing the fee-for-service revenue that was available to the system? So while we made the pivot to value-based, we couldn't take our eye off on our diligence around maintaining the integrity of that fee-for-service revenue cycle. So there's a lot of reports in Analyze. There's a lot of reviews we would do in real time with the basic management reports in Genius Med to make sure that on a day-to-day, week-to-week basis, we were capturing all of the available revenue and it was adequately documented. The last comment I'll make is regards to sharing data across real time, particularly in a fee-for-service world, is we had a lot of development in the ambulatory and post-acute space, particularly around our SNFs and our geriatric divisions. And what we noticed with the electronic health record didn't unify all of those locations. Many of the SNFs were on proprietary or smaller based EMRs and didn't have the financial ability to invest in an integrated platform like Epic or Cerner. And IM became the one area so that we could track productivity and revenue across the continuum, which then gave us an understanding of resource utilization and total revenue across an episode of a 30, 60, or 90-day period. So I think those are important points, and we can discuss in more detail each of those, both in the Q&A and I think following slides. So I'll turn it back over to you, Felice.
Yeah, that's great. And so just to continue on that thought process, as value-based care is taking a stronger hold, what was your evolution into those value-based models, and how have you used some of the analytics to help the jumping off point for your organization?
Yeah, great question. Well, I have to just be very transparent that our institution, with trepidation, moved into value-based models. There's still a dialogue within our corporate executive team around how far to go into value-based and when. Again, it's not an issue of if we're going in, it's the timing of. And part of that is around, do we have the analytics and the understanding of where our risks are, where we stand to possibly have the greatest opportunity, whether it's through BPCI, ACO, or other payment models. You really need to focus your resources in those areas of opportunity that can return the greatest ROI. The financial stability of the organization depends on it. And the way we were able to look at, as an example, those particular DRGs or CPT code areas where we had the identified performance to target, so length of stay measurement, readmission rate measurement by sepsis or CHF or COPD, we were able to use our claims data from our professional billing, merge that with our institutional claims data, and identify the opportunity where both the institution and the professional medical groups were performing well and where they weren't. So when we had the opportunity to choose certain bundles, particularly under BPCI, we used the analytics of what we have, what our historic performance would be, what our regional benchmark would otherwise be, and then measure the opportunity. And a lot of that identification was out of the Ingenious Med platform. It also identified areas where we had a lot of opportunity and possibly financial risk with moving into a value-based model. And so if we were given the opportunity, we may wait and enter those bundled payment arrangements or those value-based agreements later. I work closely with our contracting department, and we discuss those areas where we can take that risk. And IM has been one platform that's given us the confidence that we were making the right choices and prioritizing when and where we made those focused efforts into a value-based reimbursement model. I hope that answers the question, Felice.
Yeah, absolutely. And as you mentioned, I want to kind of highlight some of the key components of the things that you had just mentioned and around timing and opportunity and the greatest ROI. So just to kind of summarize by saying that when data is properly warehoused, aggregated, and analyzed, can be used to proactively manage your high-risk patients and forecast against some of those metrics that you mentioned, length of stay and readmissions. Now, you also just in passing mentioned something about a sepsis case study. Can you go into some further detail around that?
Yeah, so I think it's important to reference a practical example of how IngeniousMed or data in general was used. I would make the comment that more and more health systems and institutions are being bombarded with data from all points, from whether it is your EHR and just the infinite number of data points that you can extract from an EMR, as well as other systems, whether they're revenue cycle systems or other best-in-breed systems. I think the unique way we were able to use IngeniousMed and leverage its timeliness of the data, meaning we could access data almost in real time. As soon as a charge was entered, we would have some data where some of our other systems were much more delayed, and so we were always dealing with old data and making reactive decisions and not proactive decisions. In the example of sepsis, we were able to look at just the volume of sepsis patients that our physicians were treating. And sepsis is an interesting clinical condition, and many times it's underlying to a stage 3 or 4 malignancy, or it's an acute episode, but it's in alignment with a more core clinical episode the patient is having, a chronic disease. And so when we were originally looking from the physician charge capture piece, we were noticing high volumes of sepsis as it was documented from the coding on the physician side. Some of that didn't always line up with the health system code, and many of that is because the HIM departments and others were going on clinical documentation, but the doctor's charges reflected what they believed they were treating at that point. So one, we were able to identify our true volume of sepsis by doing that reconciliation. Two was we were looking at the variance in our system of, in this example, hospitalists and critical care groups of their performance in sepsis. And so we were able to use the length of stay reports and analyze that we're much more nimble and in real time than our hospital system data, and identify just variation in performance from program to program within our 5 hospital campuses. We then took that and benchmarked that against Milliman or other Interqual or any other data source, and realized that not only did we have interfacility opportunity, but we had opportunity to certain performance benchmarks. So one was the ability to identify an opportunity, and I think that's where IM was really able to give us that data in real time. Two, to assess the opportunity, which was, again, take that data, and whether it's internal benchmarks we had within the IngeniousMed platform of our own institutions and programs, and also then import other benchmark data, whether that be Milliman or Interqual. Point three, how to take action. A lot of that is engaging stakeholders. So while IM tees up steps 1 and 2, taking action really is the responsibility of the institution. And what we were able to do is, using the Coordinate platform in IM, make sure that we were flagging patients that the physician was coding as sepsis, making sure that the nurse, that the case manager, the pharmacist, and anybody else that was using that care team functionality in Coordinate was clear that the doctor was treating sepsis. And that created certain opportunities to take action regarding pre-formatted order sets or particular labs that we wanted to use for sepsis. What we actually started doing was creating clinical workflows and clinical best practices based off of steps 1 and 2, and then using the platform in IM to number 4, measure the outcomes, which was going back and seeing we were taking an action. Did that action have the outcomes we expected in the results of length of stay, readmission rate, and volumes of our patients with septicemia? And use the IM platform in real time to measure progress. And if we didn't notice the progress we expected, then to pivot into another countermeasure, another intervention that we felt may drive change. This is to also say that we didn't just use IM, although it was a key component. We also had to merge data from our electronic medical record and other quality reporting data to make sure that we had a triangulated approach to how we were using the data and measuring our outcomes. So that's a great example and just one of many examples of how Scripps Health has used the data and analytics in IM to start taking clinical action that hopefully impacts the care that we deliver to our patients across our enterprise.
Exactly. Yeah, so by utilizing multiple pieces of insights from various arrays of technologies, you guys were able to shift the provider mindset to take the appropriate steps in the delivery of care. In this case, it was sepsis, and then taking action and measuring outcomes to tailor the process that will meet value-based insights and also control costs. That's fair to say as a summary for that?
Absolutely, absolutely.
Well, that's excellent. I'm glad that we played such a large part as a provider, a large part in the delivery of care and taking care of patients. So this moves us into the survey question for number 2. Great. Do you currently feel that you have adequate data and insights into physician and location performance? So as Jason just mentioned, he aggregated and leveraged multiple pieces of insights and analytics to build a picture and to tell a story about the risks and stratifying the patients that he had in this particular sepsis model. Do you feel as if that you can do the same in your institution? Okay, we'll give you a few more minutes as the results are coming in.
And it's interesting to see that the majority of the respondents have some data but would like more. I think that speaks to, particularly as an administrative partner in a health system, our insatiable appetite for data. The only comment I would add here is the volume of data is not as important as the quality of the data. And you will look at a lot of false data points, and you need to bring in your clinical teams and your other clinical expertise, as well as other members of the care team, to make sure that the assumptions you're drawing from your data are valid assumptions.
Exactly. So, and as we look, we can also compare that information from the survey currently to a survey that was conducted last year. The poll suggested only about 37% felt they had enough insight on location data and even less on provider performance. And today it looks as if we have about 12% saying yes, that we have sufficient data and insights, and about 22% that says some data but no insights. So Jason, how do you utilize today the dashboards to improve your location and provider performance?
Thanks, Lisa. I have to also admit our ability to leverage the dashboards is really contingent on our ability to get our medical director leaders and our other clinical leaders to find the same value in these dashboards that I may, or someone in an administrative role. So what we really did in order to get that engagement was to bring our clinical leaders or other stakeholders in the process that we needed to be our advocates for the data and the opportunities they represented, to smaller workshops where we demonstrated the type of dashboards that the leadership team and people in the C-suite were looking at, such that they could, one, have transparency into the data we were looking at, two, comment on if they believed that was the appropriate data to be evaluating, or if they had suggestions of other ways to look at that data. And by doing that, we got the buy-in of the stakeholders to then go out and be data advocates, if you will. So before we ever even put data in the hands of our providers, we engaged them in their leadership to make sure we were measuring what they believed was valuable data. Once we did that, we early on leveraged the management reports in just the base Ingenious Med platform, which you can find in the tab and any provider can access when you log in. That has really good summary reports around productivity, length of stay, coding distribution levels, and really provides you, I think, with the majority of the data you're going to need to empower the caregivers at the bedside and maybe your clinical leaders. And that was accessible in our institution to all providers. That got them intrigued, and two, I think, generated some of the competitive spirit that all physicians and all groups. We have 5 separate hospitalist groups within our institution. So it did generate some interesting conversation and best practice sharing of how they were able to have low length of stay, low readmission rates, yet maintain high levels of productivity per provider or per shift. Once we were kind of building into the culture of the organization those weekly and monthly general dashboards, we were able to get data champions to help us use the Analyze platform to start customizing more specific reports. So as an example, we would pick, as I mentioned earlier, CHF, and we would pull all the coded CHF cases, compare length of stay, readmission rates, RVUs, and other type of metrics on the Analyze platform, and really focus efforts around a particular disease state, workflow, and opportunity. We also use it really to balance production, quality, and outcome data. We are able to extract the account numbers out of the IngeniousMed platform as an example and feed those into our cost accounting or other quality measuring system, whether that be MIDAS or any other quality system. Such again, we could get a really balanced perspective. I think that IM really is ideal for practice management analytics, but I would also caution the users on this call, and I've cautioned our leaders to not just use those data points, but to triangulate them against other quality and outcome measures that may come from your EHR or other systems. Elise?
Yep, thanks, Jason. So it's interesting that you mentioned the provider competitive spirit, because I've heard from several of them that they want more embedded dashboards showing the peer-to-peer comparisons along with drill downs for the administrators like yourself into site-specific locations and benchmarking. And those are really key to improving the provider performance and location performance. But I found it quite interesting how competitive, as you said, that everybody was. So finally, Jason, as we move into the last little bit of our conversation, you had mentioned a little while ago about the unity or the lack thereof moving from the acute care space into SNFs or subacute. Can you give us a little bit more detail about how you or your organization handles the exchange of information across healthcare systems?
Sure. And again, admittedly, this is a work in progress, as I think most of our participants would probably say is the same with their institutions. And, you know, to be honest, as a healthcare system that was the core of which was our hospitals, and I think secondary to that was a lot of our ambulatory capabilities, that is clearly shifted from a strategy and reality for us, where our ambulatory networks and access points are the focus of the organization, and the hospitals, of course, are necessary, but less of the entry point, hopefully, for our consumers. So one of the challenges we had going from a hospital-centric organization to a pop health system, which put equal, if not more, weight on the ambulatory and post-acute networks, was how would we share data across that continuum? And I mentioned earlier on this call that the SNFs and the private practice offices and other ancillary sites, imaging centers, surgery centers, and others that your physicians may frequent, most likely don't have a unified EHR unless you're in one of those institutions which was an early adopter and had extensive capital support to provide that unified EHR across your system. We also are in a market where it's highly competitive. We have 4 major health systems, so each health system had its own separate offerings for its EHR and clinical systems, and we struggled with how to unify and convince our physicians to use a unified system such that we could track our performance across a continuum. One of the ways IM initially was able to help was just in that discharge handoff between our hospitalists and our geriatric teams located in our preferred network SNFs. A lot of times the clinical information and other information would come via a fax face sheet, hopefully on discharge with the patient. A lot of times the patient would arrive in the SNF and that information either wouldn't be readily available. And so it was almost like a clinical workup began again. One of the first things we did is provide our SNF providers and our SNFs access to our IngeniousMed platform from which the hospitalists were utilizing. So they could put quick comments in the cross-cover notation or care team coordination, just the cliff notes around the course of the stay of the hospital of the patient. Obviously, the geriatricians could look at what were the primary diagnoses that the hospitalist or intensivist were treating, and then have a good sense of where to start from. It also provided just ease of communication around durable power of attorney or caregiver concerns. It really started the ball rolling in our SNFs much faster than the traditional way information flowed. We then obviously utilized that and piggybacked on that and started looking at production metrics across the continuum, where we in some examples have caregivers that function as hospitalists but also do work in the SNF. Did we see a continuation of the same diagnoses that they were treating? Our productivity reports could be merged so that we could see across their various functions their level of production and areas of opportunity. So we started really as a way to communicate effectively on a unified platform, but then we've evolved that into looking at productivity metrics, readmission rates, and more recently have started really testing some discharge decision support tools. So when the physician is putting in their discharge code, it may trigger some decision support around right site of care, whether they go home with home health or a SNF or home with hospice. So we started to really talk about decision support tools in IM. Ideally, those would also be embedded in your EHRs, but I'll be honest and say that those development, when we are 2 years into a full Epic installation, sometimes the development of the advanced functionality of your EHR takes years to develop. And so IM was nimble and able to be that platform we could do this much easy and learn from, such that when we take the development time in our EHR, we could do so with focus. And that's really how we've currently leveraged it. And I'm sure there's more opportunities, and some of the participants on the call that probably also have good experiences of how to begin to do this.
Thanks. That's excellent. As you mentioned, with no unified EHR for healthcare systems, it is absolutely imperative for technologies to continue to streamline workflows and have that ease of communication, as you just mentioned, in addition to being able to reduce administrative burden. We all know that physicians are obviously being paid less, but are asking more for them to be doing these days, and their main concern is quality of care and patient care. So anything that we all can do to help reduce that administrative burden, it's very key and critical.
Yeah, I would say that one of the greatest advantages is the ability of this platform, and there's others that are very good at this as well, to be embedded in the workflow of the physician so that it doesn't impact their productivity or doesn't impact their daily work. I think that is one of the biggest fears any clinician will have, and equally so any administrative partner of theirs, that any system or technology we put in front of them only distracts them and removes them from the direct patient care. And one of the things we've worked very hard with is how to maximize the use of a mobile platform in IngeniousSmed such that it doesn't impact their workflow, that maybe it actually enhances that. One of the most recent examples that we've had is, we historically had huddled rounds where all our teams would do rounds on their 15 patients or so, and then all meet in a room and talk about it. At the same time, they were trying to do their charge capture. This really eroded the ability of the care team to collaborate on the clinical pathways the patients needed to go for a successful discharge. With their ability to do their charge capture in real time, one, it was better and much more, I think, tight AR cycle, charge capture cycle, but it also allowed them then to focus on the clinical work when that was what was needed. So I definitely think impact to workflow is something everyone has to consider with technology, and something I think in our experience, IM has not been a barrier where other systems may have been.
Absolutely, that is fabulous to hear. And thank you so much, Jason, for sharing your experiences and comments today with myself and the rest of the team and the people on the webinar in utilization of your platform for revenue optimization, data intelligence, and, as you just mentioned, workflow automation. So now we have one last final survey question before our Q&A session. And that last final question is for everyone out there: would you like to have an IngeniousMed representative to reach out to you? So hopefully you'll be able to see that on your screen in just a few minutes and answer that question. and we'll be able to reach out to you guys and talk a little further about our application and platforms. So at this point, we can turn it back over to our moderators and open it up for Q&A. There's been some hands raised in the meantime. So if you guys would like to, you can put in a particular message to any of us, and we'll be happy to get to it. I think there's a decent amount of time remaining to address some of your questions.
Great. Thank you, Felice and Jason, for that excellent presentation. We'll now go ahead and begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. It looks like the first question is about IngeniousMed data, and it says, can you export that data into other BI tools to combine with other hospital data, or is it only inside the IngeniousMed platform?
So sure, I'll be happy to answer that. We have been able to combine different pieces of data and integrate other pieces of analytics within our IngeniousMed data warehouse. Some have been other billing type of information and integration, some more scheduling integrations. So the answer to that question is yes. We would have to look into your specific workflow and needs and then have those discussions from there.
Great, thank you so much for elaborating on that, Felice. The next question is, what are the most commonly used reports by organization?
So I'll let you go ahead. Yeah, go ahead, Jason.
Yeah, sure. I'll take a stab, and I can say for ours, the basic management report tab has a good suite of reports. Again, we also use an enterprise summary report that we access through Analyze, and it has about 15 key metrics, which are number of admits per day, discharges per day, work RVUs per day, work RVUs per encounter, length of stay, readmission, charge capture within 24 hours, and there's a whole host of other data points that you can add. But we use that summary enterprise dashboard routinely in our financial report meetings. We also use them with our division meetings and our group meetings. We will also then generate the same reports, but down to the provider level. And we will provide all of our physicians a copy of their particular performance, as well as group overall performance. And what I will say is we began with blinded data, and to my comment earlier, our physicians said, we're all on the same team, unblind the data so that we can help each other. And so the evolution of these reports continues to get more sophisticated. But again, I would focus on only those metrics that are important, that are actionable, and that your stakeholders agree measure valuable information for them.
I think that's a great point. Thank you, Jason. The next audience member wants to know, is IngeniousMed used for hospitalists and intensivists only, or can it be used for other specialties? And then they had a follow-up question, how does the platform combine with different billing?
Okay, great questions. Yes, we are used for hospitalists, and we can be used throughout other specialty groups as well. We have numerous specialists and specialty groups that are our current customer base. And the second question was, can you repeat that one more time?
Sure. The second question was, how does the platform combine different billing?
Right. So we can discuss that a little bit further, but we have some integrations with back-end billing systems so that you're getting both the front-end application from IngeniousMed and an integration into the billing system on the back end. Then with any type of reporting, we can also integrate with the billing system to bring that information back if that was something that your organization would want to do.
Yeah, and Felice, I would add, in particular with regards to hospitalists or intensivists only, while our institution, all of those particular subspecialties, if you will, do utilize the IngeniousMed platform, we've also seen our trauma division, as well as our ambulatory and home-based care division, many of which are palliative providers, utilizing the platform in the home environment. I think that's an emerging market, as we talked about earlier, in one where there clearly is not an EHR in the patient's home, most likely, and there's some limitations with mobile platforms of certain EHRs. So those are areas we've seen expansion, as well as anesthesia, ER, and some of our surgical hospitalist divisions. As regard to the combining with different billing, if the question is in regards to professional and institutional billing, we allow our coders in our institutional billing side to have access to IngeniousMed if required, to help if they have queries or concerns or questions regarding what they're finding in the systems. It may allow them to query the doctor for clarification of what's in the documentation if there's a question around what they're trying to code for. That does not drive their coding. It's just a tool to help them query the providers for clarification more timely.
Great, thank you both so much for sharing your thoughts there. Another audience member wants to know, do you do any reporting based on denial?
We don't currently do any reporting based on denials. That could be something that we discuss in the future, and if we have other organizations that would like that type of information, we certainly can talk further about that and pursue it.
Yeah, and this is Jason. I would just add, well, I don't review denial reports specifically in IM. This is where you collaborate with your billing companies. If they're seeing denials, you're able to look at those accounts, look into the IngeniousMed system, and kind of to do some investigation of maybe reason for the denials. The other, it's not a denial, the missing charges or missing bills is a huge opportunity where IngeniousMed will immediately flag those where you have dates of service on the front end and the back end, but maybe something missing in the middle, for which you want to go back and make sure you have a charge. So we collaborate with our in-house billing company, and they will use the denial reports, and we'll look if we're having denial reports maybe due to what we believe are clinical necessity needs or other things. And so we're able to triangulate metrics within IM to help understand the why. So it's really about how you partner with your other stakeholders to get the answer to the question around maybe denial reporting.
Wonderful. I think that's a great point to add. Thanks, Jason. The next question is, can physicians see their own performance metrics, and do organizations like Jason's provide this? And if so, how does that affect productivity, satisfaction, performance, etc.?
Jason, do you want to address your organization part first?
Sure. Yes, we allow all our providers to have access to what I've mentioned in the management reports. It's a culture in our institution to have transparency of the data. So we do allow that. It is important, however, that you educate them on what that particular metrics are measuring and what they're not measuring, and the methodology behind that, such that they have the same understanding that you do of what that means. We're also using those a lot with our division leaders, so that they see kind of a hierarchy of data, if you will, which is how does their particular division compare with other similar divisions across the enterprise? How do providers within their division compare to each other? And how do their individual group performance compare to benchmark performance of other clients in IM? So we're able to use it that way. But yes, we allow our providers to use it. We encourage them to use it. If they're engaged in the data, means they care, and they're probably engaged in the improvement work to help improve the data. So that's all my experience within Scripps Health. But I'm sure that there's other institutions that I've talked to or clients as well, and I think again it goes to a culture in the organization of how you use data and the level of transparency by which you want to share it. It really is a success factor or not in leveraging the opportunity within the IM platform.
And so if I can expand just a little bit as well, we are currently in the process of working on an embedded dashboard within the application. And one thing that we heard loud and clear from the providers was that they did want some peer-to-peer comparisons within that dashboard. So we should be planning on having that out by the first half of this year. And you know, so that way the providers can have that healthy competition amongst themselves and see how they're performing.
Wonderful. Thank you both for sharing your thoughts on that. Before we go ahead and end today's presentation, I'd just like to turn the floor over to you, Jason and Felice, one more time to see if you had any other final thoughts to share.
Go ahead, Jason.
Felice, I'll let you. Oh, perfect. No, I think it's obviously there's enormous amount of technology companies out there offering solutions, and as I was 12 years ago with IM, I was highly skeptical. I think the opportunity to really find a partner that is nimble and can customize your needs as a single hospital or a large system is critical. The volume of big data that's out there is just, it's overwhelming, to be quite honest. And so there is something to be said about the nimbleness and, you know, the brevity of the data. And I think IM has obviously the opportunity to provide big data, but its core strength is in its direct attribution to the physician charge. One of our biggest issues was physicians and administrators alike would always deny the accuracy of the others' data because it wasn't their own or it was somehow flawed. And I think what we've come to as an organization is a clear understanding that the data in IM, because it is directly off of the physician's input, is accurate reflection of their work and their productivity. And obviously it's not the only measure, but it is one that we all agree on, and we have been able to streamline our contract negotiations, our staffing requirements, because we have agreed on a common data source and we agree on the methodology. So I think it's important to understand that the culture of your institution is really important of the value that you get, and the recognition that while our institution has had a long-standing relationship with IM, there's clearly a lot of players in the market, and just do your due diligence on the organization you're partnering with, because a lot of damage can be done using wrong data or using misinformed data. Felice?
Yeah, so for me, I would just like to thank you and Scripps for your partnership, and especially today, Jason, with your partnership and conversation for this webinar, and just echo your same sentiments of make sure that the data is actionable, that the providers and the administrators both agree on the information that is given, but also that you can take it forward, make some decisions, provide really good quality of care for the patients, which is what we all really try to do, and then also control costs in the process. So thank you again for everyone's participation today and Jason's partnership in this webinar as well.
Thank you.
Wonderful.
I hope it was valuable to all.
Wonderful. That is all the time that we have left for today. I want to thank Jason Cook and Felice Selzer for sharing their insights and our audience for participating. Looks like we have one final poll question before we go ahead and end today's session. It should pop up on your screen now, so feel free to answer. And as a reminder, we will be sending out all poll results to participants of the webinar following the presentation. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.